So, as we went through the whole carcinogenesis and chemo prevention So now this was the last slide, but that's a very important slide, because now we know that we have a drug, we identified a drug that we want to take it forward and for the Food and Drug Administration. So what we have done is we have a compound that we isolated from the herbal or natural products or made it a synthetic compound. Now that compound we evaluated all its activity and it showed positive reasoning to go forward. But then the next step is something that you are entering into a very expensive affair, very expensive way to do that. So you have to be absolutely certain that this is the drug that you know is going to, change the field and going to have a lot of impact in the prevention or therapy of cancer. So after you decide that you want to do that, and I say that, but nobody does that. Everybody wants to have that drug seen go through the FDA, but it's a very, very expensive process. So this is the process you go through. You have a rationale to go through. So we'll talk about vitamin D, because we have done that, and I know pretty well. So we have to have a rationale. So we said that okay, vitamin D that I identified has really good activity. It has molecular target. It's showing very good cancer preventive activity. It's showing good cancer therapeutic activity, and it looks like we are going to be okay with it. So usually what happens is some of these studies are so expensive that the funding that you get for your research from the government usually is not sufficient, because it costs lots and lots of money to do that. And I'll go tell you as soon as we go along. But then we decided that okay, we have a rationale to go through. So that we have to do a preclinical toxicity studies. Preclinical toxicity studies are required to be done in 2 unrelated animal models. So it is done either in rats and dogs, or it's done in the dogs and monkeys, or rats and monkeys. Now monkeys are very, very expensive. So monkeys cost like about $1,500 a monkey, and so it's, it's going to be very cost ineffective, and you don't know whether your compound is going to be toxic or not. So in case of vitamin D, we selected rat and dog to go through the preclinical toxicity. This costs about $500,000 to do that, because they have to do a 28-day toxicological study. But the money comes in picture because it is called a good laboratory practice. The study has to be done under GLP, good laboratory practice. So everything has to be documented. You have auditors, they audit your data, they find that okay, you did not sign, you crossed your result here but you did not sign, things like that. So under this condition, you run a preclinical talks and say that okay, my compound is non-toxic. So then this study can be done on some compound that is synthesized in the lab. One of the synthetic chemists synthesized the compound, so okay, he's a collaborator, he's not going to charge too much money, we're going to have some compound that we do it. Then you go into the for clinical trial approval, you have to have the compound synthesized under good manufacturing practice, or called GMP. That's very expensive. Just like GMP synthesis is super expensive. So what we do in the United States is we go to India or we go to China, where it's a little bit cheaper to have this made. So we had our compound made by Sai Pharmaceuticals in Hyderabad, and they made vitamin D. So now you have a GMP drug. It has to again test it in your system to make sure that the compound is good, gives you the same or similar results. Then you have to look at the drug stability, because what the FDA wants to know is how stable the drug is. And so you do different temperatures, different capsules, you do say whether the drug breaks down. So for example, if you are in Amritsar and somebody forgot the bottle of that pill in the back of the car in the and the sun is shining in summer, whether it's going to break down. So you have to do the temperature study. That will tell you whether you are required to leave the drug at what temperature, in the refrigerator, or it is stable at a room temperature, or it is stable in the hot temperatures. So you do the drug stability. And then you have to come into the formulation. So you have to do how you are going to give this drug to the patients. So you have to have the formulation done. Now there are formulation chemists, they just do only nothing but formulation. So you have to go through them. They have to make sure that it's going to be released properly in the right concentration when the drugs are taken, the tablets are taken by women, or injection, whatever. Then you have to look at the stability of the capsules. So we made capsules from that. That's what we had made of vitamin D. So we have to see whether the capsules are stable. When we do all this, then we write a proposal for FDA and put all the raw data, and the proposal becomes this thick. So all the raw data and everything, and you submit it to the FDA. Now FDA promises that they will let you know in 30 days. And just almost always, without exception, on the 29th day, they will tell you that these are the problems with your drugs. And there is a reason, because if they don't do it on 30 days, you automatically can start your clinical trial on 31st day. There is a law. Say, okay, I didn't hear from you, I started my clinical trial. So there is not a single incident that I know where they have missed. They always let you know that okay, whether your drug is approved or not. You also have to have the IRB submitted, because you are going to give it to the patient. So the medical center has to say that okay, you write the IRB that it's okay to give it to the patient, and you submit that to the FDA. In this 30-day period, you can also discuss with them, and that's how your drug either approves or gets rejected. And they can suggest that okay, you need to do this, and then you can go ahead and resubmit it. There is no problem with that. But then again, it's a long process. So that's how the drugs are selected. Internal review board. Within the university, every medical center has one, IRB center. Any protocol that you do for the clinical studies, it has to have the IRB approval. Just like the, I don't know whether you have it, but the animal protocols. Animal protocols, you have a small animal committee, care committee. Like every university almost have to have it, those who are working with in vivo studies. It's just like that for human. You need to have the you need to have the physicians involved in evaluating. Yes. Okay, so what I'm going to do now is, as we had said, in the afternoon, and there is a next part, next slide after this, but that I'll come later. Okay. So what I'm going to do is I'm going to go switch gear here, and we are going to go and open up another lecture. Some slides will be repeated. I'll go over quickly. Okay. Okay. So as I had told you before, that when we were doing these videos, the videos were not really in my mind. I was not very happy yesterday when we did the video, because the videos were good, but when you do the I cannot explain while it's somebody is really trying to explain, and I thought that the message was getting lost. Like the signaling, the lady was talking about MAP kinase signaling, which is very important, but I don't think that at the end of that video, anybody could say that, okay, what's happening, where MAP kinase works, because it was too fast, and it was not really the right way to do. So after talking to Professor Arora, what we had decided, I told her that what we'll do is I'll give you a practical knowledge about how these things are done in my lab. So instead of giving in the afternoon really a basic concept type of a lecture, like we've been doing, like carcinogens and carcinogenesis, or just a broad global, I'll give you a selective thing. Now I have to apologize for one thing, because I was not really planning on showing this one, and this is the only one I have as one of my presentations on the computer. The other one is in the lab computer, but this one was done in 2010. So this is the older work, but as I go along, I'll tell you the current status of where I stand. Okay, so so it's in our current research laboratory. I went through this slide before earlier today, so I won't spend too much time on that, but that's how the drug is discovered. We use MMOC and cancer cells as our models before we go into the experimental carcinogenesis and molecular mechanisms. We do the screening, we select the drug. If all this work out, we go to preclinical toxicity and we go to the clinic. That's a nutshell. Okay, this Okay, now what happens is, one of the things that is very important in carcinogenesis is there is a really strong target organ specificity. So you discover a drug, and if it did not work in breast cancer model, it does not mean that it's bad. It could work in other models. It could work in colon. And I wanted to show you the slide here. Now fenretinide is also my compound. That's a vitamin D. It's a 4-hydroxyphenylretinamide, which was discovered in our lab, and it was really my drug. And that's in the clinical trial in Italy. Clinical trial was completed, and it's good. So it's active in breast cancer and in oral leukoplakia system, but it's inactive in esophagus and colon. Okay, so if we started a study with fenretinide and your model is colon in the lab, it's not going to work. So don't get discouraged if something that you discovered doesn't work, because there is a very good chance. And one thing to remember when you do that is that if something that does not work in the epithelial cell system, the system that is in the tissues derived from epithelial cells, then if it works in the epithelial cell, it's not going to work in colon or endothelial cell derived. It almost is never, it's always a problem. It's always no cross reactivity. Many of these, so as you'll see, like vitamin D, it works in colon, breast, prostate. That's a unique condition here, that it works in both of them, but it doesn't work in pancreas or lung. We tried, it did not work. Garlic, which many of you here have interest in, all the garlic compounds like diallyl disulfide and acetylcysteine and things like that. They work beautifully in lung but doesn't work in breast. Or selenium works in breast and colon but doesn't work in lung. So folic acid works in colon but doesn't work in breast and prostate. So what that means is that there is not one size fits all concept. It's not that okay, one is going to work on every, in every organ or every system. So when we, in the lab, whenever we do the studies, we look at the chemoprevention, chemotherapy, and mechanism of action of the compounds that we are working on in general. We have a focus group. This is 2010, and people who I'm going to show you here, I retired, so they are not there. So basically, but many of them had gone long before that, because this is 2010. Many of new ones had come since then who are not on here, but I'll just kind of want to give you an overview. So next 2 days what I'll do is I'll select couple of these today and couple of them tomorrow, and we'll go from there, see how how it pans out. Okay, so we have breast cancer, we had, and we still have, until I retired we had it, but we have a breast cancer project which is our major project. We worked on the vitamin D, which you all know is, I spent lot of years, many years on vitamin D prevention therapy. This is aromatase inhibitor, which is very important, because what happens is that in the premenopausal women, you have you give tamoxifen to the breast cancer patients. However, in the postmenopausal women, you're not going to have a tamoxifen that's going to be effective, because you don't have that many estrogen receptors. But you have adrenals that secrete estrogen. So you have to prevent the synthesis of estrogen. So what you do is you have to give aromatase inhibitors, and there are many of them in the market, and the letrozole is one of the main ones. So what happened was that I had a graduate student, Akash. Akash did his thesis on aromatase inhibitor, and just did beautiful work. So I'll show you as we go along what he did. Although I have only 2 or 3 slides, because he started around there and he graduated, and he accumulated a huge amount of data after that. And I won't be able to, I'll point out what he did after that. Then we have a lung cancer group. So we worked with resveratrol and sapotin on efficacy and mechanism of action. Now I had a postdoc from Ireland, Lorna. She did a work on resveratrol and lung. That's a beautiful work. That's really good work. And we published it in Cancer Research in a really, very pretty high-profile journal. Sapotin is present in chiku, in sapote, and we have not done too much work on that, although the compound is very good. So if any of these compounds that just attracts your eyes, just capitalize on that and start working, because there is not much. Don't pick resveratrol. Resveratrol has 3,000 papers in our paper, so don't do that. But sapotin, not many papers are there in the literature. It's a good compound, and you study efficacy, mechanism of action. Then I have a colon cancer group where we work on vitamin D, daguline, sapotin, efficacy, mechanism of action, and so on. Same thing. Mouse mammary gland organ culture, as I was telling you, that we screen potential chemopreventive agents. We do the gene arrays for the precancerous lesions. So the idea was that it's not a cancer, it's just precancerous lesion. It's just the lesions that did not respond to hormones. When we remove the hormone, the lesions are growing. So can we select genes from there to further work? So if you can select the precancerous lesion, which are not cancer yet, it's pre-neoplastic, can we identify a gene or two which we think are different from normal and which may have possibility of be involved in cancer formation? Well, that would be a huge big step if we can do that. So I had a group, we were doing work on that through the grant. Then I had a drug discovery, I was head of this group also. It's a synthesis group. And this is a funny story. Rajesh Naithani, he's from Dehradun. So he was like a senior scientist. I don't know anything about first thing about synthesis, but they said that can you oversee, and I said okay. So Rajesh was in charge of this, and then in the one time he came to India and he talked. I don't know what he did. He must have talked to chief minister of their state, which is Uttarakhand, right? So and he came back and says, "Sir, I'm going to leave." I said, "What's happening?" He said, "I'm getting a government job in India." So he's really big now. He's in federal government in New Delhi. He goes to South Africa, and he knew that I'm coming here. So he says, "I'm going to come pick you up from from here and take you to Dehradun." I said, "I don't have that much time, but last time when I went to Dehradun, he took care of me really well." So this division is closed down now, but those are the different things that we were working at that time. So we'll start about this one. We'll start talking about this one first. And as you can see, except for Karen, who is doing the gene arrays, and this is Pang, Chinese guy who was working with me for about 10 years, and then she's from Middle Eastern countries, Saudi Arabia. And Akash and Avni are from here. So looking at that, he's still there. She's in Berkeley doing postdoc. Akash is in Arizona doing postdoc. Avni finished MBA and she's working somewhere in Connecticut. Okay, so I won't go through this, but briefly what I'm describing here is that how vitamin D is made and how it is metabolized, and things like that. So how I'll talk about this on the when I'll talk about how everything comes together day, like the last day, on the last 1 hour. I want to show you how everything that we talk about, all the regulations, all the growth factors, all the metastasis invasion, how everything comes together in our studies. So I won't go through this one, except saying that you can get the vitamin D from sun, and it gets metabolized. Tissue metabolizes also to active form. It works against all these diseases. But there are a little bit of things that I have to tell, but I won't tell you here right now. But it has a bone effect, immune effect, a very good class of compounds to work. And there are many adverse effects, which is hypercalcemia, soft tissue calcification, and weight loss. So what happens is that people synthesize analogs, and there are some 1500 analogs known in 2010. Now there may be many more. So many of them got processed by got approval from FDA, like EB1089 and all these compounds. Some of these compounds, like this is a Roche Pharmaceuticals compound, and this is from Switzerland. This one is done from Abbott. So you can see they are all multi-million, hundreds of millions of dollars of company, and this is me, poor guy, working on the bare minimum research grant with putting money from my pocket to buy some chemicals, but it got approved. So we were very happy. Even if we did not go any further after this, our thing was accomplished. That we were very happy that our research was fairly well recognized. So I just showed you this slide a few minutes ago. This is a anti-carcinogenesis, anti-promotional, but this slide shows when we give from this all the way to here. This is a control. This is a high dose of vitamin D5, and this is the middle dose. And these results we had published in Journal of National Cancer Institute, which is the best journal in cancer in the world. This is cancer research and JNCI. But if you look at the impact factor, JNCI has better impact factor than cancer research. Okay. So we work on a variety of different cell lines. The cell lines you select based on what the properties of the cells are. So these cells are all estrogen receptor, progesterone receptor, and vitamin D receptor positive, and these ones are here estrogen, progesterone receptor negative, but VDR positive. MDMA 231 is triple negative, everything is negative, but we also made the one where estrogen receptor positive, we borrowed from somebody this cell line called S30, and you have ER positive, PR negative, VDR negative. And then this we generated in our lab by transfecting VDR into the cell. So we had all kinds of cell lines available to our disposal to work with these compounds. Aram Hussain was my PhD student. This is the summary slide from her work. So we looked at the effect of 1-alpha D5 action on cell cycle. So what happens after the vitamin D is incubated with this cycle? So these are very tedious studies. You have to do hourly. So she said that the vitamin D positivity occurs like in the first 8 hours. You have the P21, P27 negatives are coming up in 24-48 hours. You have the PRB getting hypophosphorylated. So you're looking at the G1 stage. You get the hyperphosphorylations occurring. You have apoptotic components coming up. You have these negative ER alpha PR. All these are becoming affected within 30 to 48 hours. So she, in her thesis, she really mapped out the whole effect of vitamin D. And the other thing she did was she took the normal cells, normal-like cells, which is called MCF12F, and she transformed this with carcinogen MNU and DMBA. So she made 3 cell lines. So you have a transformed cell, you have normal cell, and you transform with two different cells. And then you look at the growth arrest and do all the immunofluorescence and everything else. Pang, in this, when we were doing this, we found a gene called prohibitin. So the way it was done was very nicely. So we had we did a gene array, but gene array using only like 100 or so genes, not like the whole large system of it. And we selected, what we did is we took the control cells and cancer cells, and we compared the genomic profile and found out the genes that are different. So there are like few hundred genes that were different from this to this. Then we took this cancer cell and treated with vitamin D and found out which genes are different from these differentially expressed genes. And we came up with a list of our 7 or 8 genes, and we said that prohibitin is the one that is involved in cell cycle according to literature. So we said that it's involved in the vitamin D action. This is a confocal microscopy. So if you look at the prohibitin, if you look at prohibitin expression is there. There's a vitamin D expression. This is control. This is VDR. and then we co-localize them, and you say that prohibitin co-localizes with vitamin D receptor, meaning there is a mechanism by which VDR works with prohibitin. So this we had published in Cancer Research some time back. So one of the things, each one is a project, but I'm just going through the projects here. Okay, so this one here, one of the things that had crossed our mind, which is somebody asked me a question also, I forgot in the lunchtime. But vitamin D, we take vitamin D every day. If vitamin D is going to inhibit cell growth in a pharmacological stage, then why is it different? Why it's not killing normal cells, right? So we had a question asked in terms of physiological and pharmacological differences, why the proliferation, why there are differences between physiological condition and the pharmacological condition. These are just the examples of the different actions, but I'll show you. So if you look at a physiological effect, physiological role of any vitamin D is really to maintain cell proliferation. That's why we take vitamin D, right? And pharmacological, it inhibits cell proliferation. So how can you live with this kind of controversy? So we did a lot of experiments, and this was Avni's master's thesis. She kind of narrowed this down. We had this question, and now she's MBA. She doesn't do science anymore, but she did the postdoc at Harvard. So I mean, not postdoc. After MS, she got a job as a technician. At Harvard, and then she got married and moved to Connecticut and did MBA. And now I think she's a kid and looking for a job. So just a likely story, right? So this is MCF12F in normal condition, and if in normal condition, you can see that vitamin D would inhibit the growth of the cell growth. Now this one is MCF12F in stress. So we do the stress by many different ways. You can do the hydrogen peroxide, you can do the serum starvation, you can do many different ways. You can induce the stress. So if you look at the under stress condition, the normal cells don't grow as much as the regular cells. Okay, but when you put it with vitamin D, it prevents this depression. See what I'm saying? So for example, it prevents the stress factors and in the normal cells. So maybe when we say that it uses cell maintenance of the cell under physiological condition, that is probably real. Otherwise, here you have inhibition, here you have enhancement. And then we did many proteins, P53, PCNA, which is the proliferating markers, and all that, and we won't go into detail of that. At that time, we just had started working on microRNA. MicroRNAs are small 60 nucleotide RNA that regulates many regulatory genes in the body, and it has become a huge big science now. So one of Fatima, I just showed you the one from the other one. She had a project to identify a new microRNA, and we did really beautiful work on that, and I'll show you on the last day. Okay, so I'll skip this slide. But her thesis, this is her thesis was on four-count polymorphism. So this is a different project. This was her PhD thesis. So what happens is that VDR, the normal VDR, has this is normal VDR with small ff. So what happens is it has a 427 amino acids, and there is a polymorphic form of vitamin D where one nucleotide is changed. So when one of the nucleotides is polymorphic, it changed it. What happens is the gene, the translation begin from the next initiation code. So you have to go to ATG in the sequence to see where the next ATG is. So that was 3 amino acid down. So you have to have, so this one is a 3 amino acid short. Okay, this FF is 3 amino acid short. So epidemiological studies showed that VDR-FF are more at risk of developing breast cancer as compared to VDR-FF, big F, which is a shorter VDR gene, and that is more prevalent in the black population. And black people have higher incidence of breast cancer. But there was no experimental data to support this due to lack of approximate. How are we going to have a cell line that has the VDR-FF or VDR small f? We don't have cell lines like that. Okay, so the question is, what is the functional significance of this? And that can be studied only in the experimental condition. Epidemiology cannot tell you that. All they can do is measure. So her thesis was on this. So what she had done was, from a single cell, one cell, she generated a cell line of all 3 kinds. So that was expressing control, VDR-FF, okay, so here we go. So she took the cell line, which is the MCF7 cell line, expressing very low VDR. That was with vector. She transfected with small f, she transfected with big F, and then she studied the cell proliferation, designaling, molecular mechanisms, ER alpha signaling, apoptosis, metastasis related genes, and all that. And she got her degree in 2014. So this is, after that she worked for 3 years on this. But she did a really good, good job on this. So this thesis got prize also. So this is established 3 cell lines from single MCF cell lines. Okay, these VDR-FF are more responsive to vitamin D than the small f, which is a full component. They are more stable than this one, and this is very early work. They express less BCL2. So all these are correlating, indicating that patients expressing small f VDR may be at a higher risk of developing aggressive tumors and possibly metastasis. Now that's a really good thing. So you have a patient coming in, or people coming in, because polymorphism is in every cell. If a person has a different thing, it's going to be in every cell in the body. So like if you can identify or do the screen and see if the person has a VDR-FF or FF, you can at least tell that that patient is going to respond to vitamin D or not. So when we are going to have the clinical protocols, we can say that, well, in this protocol, should we really give this person vitamin D if it was in the clinic or not? So it's okay. Let's figure out what the VDR, this FOC1 status is for this gene, and you can say whether it's going to respond or not. So she finished that and did clinical samples, and she worked very hard, and then got really nice data, and she got PhD for doing this work. Okay, Akash is. He's now in Arizona, but this is pretty much when he started his research, so he doesn't have too much data in this one. But here we say that treatment with aromatase inhibitor is a treatment of choice for breast cancer patients, for postmenopausal patients, and these patients usually develop resistance to AI sooner or later. So there is a need for some new effective way of treating these patients. So they cannot be done in vitro, and the reason is that the enzyme, aromatase enzyme, is in the liver, and you don't have liver in the cells, breast cancer cells in culture. So you have to develop a line that will express aromatase. So you can look at the effect of compound on aromatase inhibitor. It's like in the cell line, if you had aromatase there in the cells. So what he did is he transfected the cells with aromatase gene, and then confirmed that the cells are expressing aromatase gene, and then you have control with no aromatase gene, and then the compound which is in the clinic is called letrozole. Letrozole is an aromatase inhibitor, which is in the clinic. So he took one cell line which had this aromatase gene and treated with letrozole, and he treated for 6 months every day. And then he found the letrozole resistant cell line. So now you have aromatase expressing cell line and you have a letrozole resistant cell line. What you want to do is whether the compound that we are working on called ProLX. So whether the ProLX is going to have any effect on aromatase producing cells, and if yes, can it also inhibit the cells that are letrozole resistant? So if the letrozole resistance is going to definitely occur in patients, so if the patients have a letrozole resistance occurring, can those patients respond to our new drug? That's the idea. So that's what his PhD was on. So we worked through progesterone receptor and a lot of research. So he got a thesis out of this. So he has to have lot of work done on this. So he at this time in 2009, he had asked a question: can we develop a cell line that overexpresses aromatase? Does it respond to aromatase inhibitor which is existing, which is letrozole, and anti-progestins, which is ProLX? And can we make this resistant to be aromatase inhibitor? Now, why we selected anti-progestin is because the aromatase converts testosterone into estradiol in normal body. So you are looking for anti-progestin, which is going to be the next step in the synthesis for the in the steroidal cascade. And then what would be the mechanism of action for the AI resistance and ProLX action? So that's Akash. And this is his data. He generated a cell line that expresses aromatase, and this is control, which does not have any aromatase activity in there. And this is a messenger RNA expression using the RT-PCR. Okay, so then he had looked at the COX-2 and things like that in this in this system. So I'm not going to go into that. I won't be talking about his work on day after tomorrow also, because it's a big seminar in itself. Okay, how are you doing with time? Okay, let me see. I can switch to another one which is a smaller project. No. Okay, let's do this one and then we'll stop. Okay, so this one is Nitin Tiwari. He did his MD from New Delhi and he came to States and he did MS thesis with me. He really was pretty crazy and wanted to do research. Very bright guy. So like for example, okay, I have to do this work at night and I have to do the time course, or my time comes at 2 o'clock in the morning. So he'll sleep in the lab, but he'll sleep there's a window, and the window had little space like that, so he'll climb up there and sleep. So somebody comes in the morning and says, what are you doing? What's he doing there? So we had kind of one thing which I personally was very fortunate is my group was like a family that come to my home, eat whatever are there in the refrigerator, go there. So this guy was pretty crazy, but now he's practicing medicine in Baylor Medical School. So he's pretty smart guy. So he had another thing is that you have to take the UCMLE, and UCMLE part 1 he had 100%. So he's like pretty feisty. Okay, so he had a concept, and this is really a mind-boggling concept. He said that the expression of steroid receptor is regulated by hormones. We all know that the estrogen receptor is regulated by hormones. Now splicing through though having significant overlap with transcription and post-transcriptional modification, it's an individual phenomenon that can be individually regulated. So in other words, what happens is, I'll show you in the next slide what the splicing looks like. Some of you who don't know what splicing is, So the receptor gene splicing is an additional level of gene expression. Okay, I'll show you what I mean. And control, which is still yet unknown, and how hence amplification. So what it's trying to say is that the vitamin D receptor molecule, or the precursor of that, is a long molecule, and now that has to be chopped down to the active receptor molecule. Okay, so that happens by a process called splicing. I don't know where my splicing thing is. Okay, so I'll show you. I'll show this day after tomorrow. But what happens is that the gene is located in a way. You have exon, you have intron, you have exon, you have intron. Exons have activity, introns don't have activity. So by some mechanisms there's a splicing occurring. There's a constitutive splicing where the introns come off and the exons join with each other, and which is going to form a transcriptional complex or a complete working RNA which will make a protein. That's how molecular biology works, like in cell, in life, that you have the introns that will come off, and then you have alternative splicing. So what happens is that you have all these exons all around, and then you have an intron that gets spliced, but the exon comes off and doesn't organize exactly in a series. They can come up and hook up here. So that makes a change in the protein structure, and that's called the alternative splicing. So forget about that. But what it is, we really don't know what this splicing, what is regulated, what regulates splicing. So what, there are only a couple of slides and then we can call it a day. Okay. So for example, if you look at this one, you have a CYP24 splicing. CYP24 is required, it's a vitamin D target gene. Okay. Because CYP24 is required for metabolizing vitamin D into 24-hydroxy D3. So it's a target gene. So when he did this, this normal CYP24 is right here, the gene. When he treats that with vitamin D, this one gets spliced. In the absence of vitamin D, it does not get spliced. It does not break down in the absence of vitamin D. So what that means is that, and then he's going into the different introns and things like that. So what it means is that the splicing of vitamin D receptor is regulated by vitamin D. In the presence of vitamin D, vitamin CYP24, which is a vitamin D regulatory gene, can be spliced. In the absence of vitamin D, you cannot. Well, that's a huge big concept. It's like nothing is known like that. So for example, and we did some work also with other receptors. So for example, estrogen receptor, which is huge in memory gland carcinogenesis or breast cancer. So is estrogen required for estrogen receptor splicing? And that's a huge big concept. And well, Nitin published this work in a really good journal. We submitted it to Nature and Science, and it did not get accepted. But because it did not, we had limited data. But it's just really a good concept to follow. Okay, so I'll stop here. And we'll discuss. So then we have the tomorrow I'll show you other. Questions?
So what was the aim of splicing of this vitamin D?
That's a vitamin D regulatory gene, CYP24. CYP24 is cytochrome P450 number 24, right? It's in the liver. All CYPs are in the liver. And CYP24 is a target gene for vitamin D regulation. So in the vitamin D, which is just the original molecule, gets broken down into 25 hydroxy vitamin D. that requires an enzyme which is a CYP enzyme, CYP24. So the splicing occurs, we know that, like in the body or in any gene, that splicing is going to occur. In order for a CYP24 to be active, it has to have this long molecule become shorter by removing all the introns and have all the exons connected. Now that happens, but nobody really knows how it happens. They say that constitutively it's done, but the regulation is not known. So what he wanted to know is it regulated by its own ligand? Like vitamin D, CYP24 breaks down vitamin D, so it's a vitamin D regulatory gene or target gene. So whether a ligand can also regulate the splicing of a gene of its target gene. So it's a hormone targeting its own gene. Now that concept is very novel. It's pretty provocative. So he asking me that he showed me the data a couple of times, and I just wasn't sure that's right. But then he did the whole thesis work of data on that, and he showed all different genes, and then he said the vitamin D has many other genes and that are regulated VDRs and interferons, and he showed all that. Some of them are spliced, some of them are not spliced in relation or in response to vitamin D, and I'll show some results tomorrow. So, yeah.
So as you have shown that vitamin D is so important, and it is plays great role in as a chemotherapeutic agent.
Yeah.
So we must maintain the level of vitamin D.
Yes.
And as it is so important, because the deficiency may lead to a number of problems.
I think that maintaining the vitamin D level in the body will probably solve many problems, because it's still a very essential vitamin for many things. All the.
Is there any data regarding this correlation that the ones who are vitamin D deficient, they are suffering from such?
Yes. There are lots of epidemiological data. So, for example, the most important study that was done in the United States, that there is in the northeast by New Hampshire and Vermont area, where the sun is very like a lot of snow and the sun doesn't come out and people stay inside, as compared to Arizona, for example, where weather is like Amritsar, where it's very hot and humid. So they compare the levels of vitamin D in these two populations, that they have the low vitamin D because they don't get exposed to sun as much, so they don't have as much vitamin D levels in their body, and they have higher incidence of cancers.
I think there should be doing small projects to the graduate students, like, to collect the data. As Amritsar is having a lot of sunshine there, but even then the people are suffering from vitamin D deficiency, and maybe the lack of awareness that vitamin D is so important and leads to so serious disease. So this data is not there.
It's very important. I mean, it would be a really very nice study to see. So, all it requires is the blood and measure the vitamin D levels, and see how. And you don't measure when you do this. There are kits available, so it's very simple. And you don't measure vitamin D. You measure 25 hydroxy vitamin D3. That's the metabolite, which is what gets correlated in the vitamin D study. So it's a good purpose. Okay, if there are no more questions, I think we'll.
Tomorrow we start again at 10 o'clock. You have the feedback or form giving.
Over tomorrow.
The morning we give the feedback. fill, and you can go online also. There is provision of filling the feedback online, and you fill that also. And part of the
सर्टिफिकेट ਦੇ ਨਾਮ ਵਗੈਰਾ ਵੀ ਚੈੱਕ ਕਰਨਾ
सर्टिफिकेट का मेल करके किसी सारे ਨੂੰ ਆਵੇ ਸੀ ਕਿ ਤੁਸੀਂ ਆਪਣੇ ਪ੍ਰੋਪਰ ਨਾਮ ਦੇ
ਕੋਈ ਐਫੀਲੀਏਸ਼ਨ ਬਦਲਣਾ ਚਾਹਨਾ ਕਿ ਕੁਝ
otherwise also you can
सेफ्टी ਦੇ ਆਧਾਰ ਕਰਤੀ ਹੈ
capital से अपना नाम
ਜਿਹੜੀ ਟਾਈਪ ਕਰਕੇ ਸਰਕੂਲੇਟ ਕਰ ਰਹੇ ਨਾ ਇੱਥੇ ਜਿਹੜੀ ਕਰੈਕਸ਼ਨ
सर्कुलेट से देखना अपना स्टाइलिंग वगैरह
affiliation of the designation of